The risk factors for falls and preventative interventions are well established. They're, frequently cited in the literature. Over the next few minutes, I'm going to review the most common risk factors for falls for older people living in the community. We'll also talk about the preventative interventions and how to focus on patient engagement using the 4Ms. So we know that fall risk increases with polypharmacy. In most studies, polypharmacy is defined as 4 or more drugs. The reality is that many older adults who are seen in primary care are on at least 4 medications, and this increases their risk for falls. The CDC recommends the safe medication review framework, whereby you first screen for medications that might increase risk. You assess the patient to best manage their health conditions. You use that to formulate the patient's medication plan, and then you educate the patient and caregiver about medication changes and fall prevention strategies. There have been many studies that have highlighted the linkage of certain medications to increase fall risk and the importance of identifying these fall risk increasing drugs or FRIDs, and then engaging the patient in a deprescribing plan if possible. And on the right of this slide, you can see the most common FRIDs that you'll see cited in the literature. A deprescribing plan includes first stopping meds when that's possible, but we know this is tricky, especially when patients have been taking certain FRIDs like benzos for years since they were in their 50s. And so here's where talking about the meds in terms of what's really important to the patient and how the medication plan can be revised to support their wishes and goals. The medication plan can also include switching to a safer alternative or reducing the dosage of the medication to the lowest effective dose. Another risk factor for falls that can be tricky to treat is postural hypertension. So by definition, postural hypertension is a drop in systolic blood pressure of greater than 20 millimeters of mercury, or in diastolic blood pressure of greater than 10, or they're experiencing lightheadedness or dizziness, which is considered abnormal. Interventions that can help, including teaching patients self-management skills like increasing their fluid intake, reducing consumption of caffeinated beverages, making slow position changes. So when they're first getting up in the morning, getting up slowly and gradually, and wearing elastic stockings. And then continuing to monitor the symptoms in response to their self-management plan, and then further evaluating for medication changes or referrals if needed. Visual impairment also increases risk for falls. In terms of the assessment, it's important to encourage regular eye exams and to ask patients about corrective lenses. We counsel patients about the importance of the regular eye exams, about the importance of not wearing multifocal lenses, for example, outdoors or on uneven surfaces. That's a very common way that people fall, or reason for people to fall. And then, of course, making referrals as needed. Problems with the feet and footwear can also increase risk for falls. As part of the annual assessment, look for chronic or new foot problems, nail problems, which can lead to unsteadiness. Also note the footwear that the patient came in with, and then you can use your observation as the basis for your recommendations. Inadequate vitamin D intake can lead to impaired muscle strength and neuromuscular function, can also decrease bone mineral density, which can increase the chances of instability and the risk for fracture with a fall. And so the evidence suggests that vitamin D deficiency is very common in older people, particularly in the Northeast, that this deficiency impairs muscle strength and neuromuscular function, that vitamin D it's effective for fall prevention, and this is distinct from its effect on bone health. And the benefit is even in older persons who have a normal serum vitamin D level. And so the recommendation is that we should provide a recommendation for people to take vitamin D supplements unless it's contraindicated. So osteoporosis and osteopenia also place people at risk for falls. And so as part of your assessment, you review the Frac score. You can calculate a Frac score. This can be done easily. There's many tools that will help you do this online. But if you don't have time to calculate, but it's really you might not have time to do a Frac score in the context of a visit, and so really just watching the patient, walking into the exam room and seeing how steady they are. Are they using a assistive device? Are they using it properly? So those kinds of observations can also help with assessing their safety. So home hazards are also a common reason why older people fall in their homes. It's rarely possible to do a thorough home assessment while you're having a conversation with the patient, because the patients are often unaware of the hazards that exist in their home, or they might be aware of them, but they're not willing to address them. So for example, during the STRIDE study, the nurse falls care managers would very often say to the patient, oh, you really shouldn't have these scatter rugs. Should we pick them up? No, I don't want I like my scatter rugs. It makes my house feel like a home. And so, coming up with other recommendations like taping the rugs down are sort of a secondary recommendation. So here it really helps to use some patient and family home hazard risk assessment tools. There's a really good one on the STEADY website. We'll be talking about STEADY tools later. Encouraging the patient and involved family members to use the assessment and then to make the changes to help them realize what matters most and help them to explore the barriers, including affordability of the recommendations. So fall risk factors of weakness, gait and balance concerns, these are very common in older people. Conducting an assessment like the short physical performance battery can help you identify and quantify gait and balance needs. There's many tools online to help you do this. So again, you may not have time to do this during a visit. So again, watching the patient walk, if they're stable, and whether or not they're using a walking aid, and use that to inform the recommendations. There are many different options for exercise. So during the pandemic, a lot of the community-based exercise programs were not running. And so they're starting to pick up again. But the problem with home exercise programs is that they start, they run, and then they end. And, I think that our messaging to patients has to be that they need to exercise every day. And so that's even when the community exercise program isn't running. And so to do that, we really need to, in addition to recommending community exercise where appropriate, we need to be recommending home exercise. An exercise program, so based on the evidence, an exercise program will prevent falls if it meets all three of these criteria. So it's designed to improve balance and strength. It's progressive, so it gets more challenging over time, and it's practiced for at least 50 hours. So here, that means if they're taking a 1-hour class 3 times a week, they need to do it for 4 months, or if they're doing a 1-hour class 2 times a week for 6 months. And so by adding on the days when they're not going to class, some safe exercises will really help with them getting the benefit of that exercise.